A very good morning to you. Now, I come from the state of Bengal, and in Bengal, we worship Ma Durga, Rabindranath Tagore, and intellectualism. And in order to look like an intellectual, you need to wear glasses, very thick glasses. So in a situation like that, doing refractive surgery, counseling a refractive patient is indeed like selling ice to an Eskimo. My father was a doctor, a physician, and I often watched him tell his patients when they asked too many questions, "Are you the doctor or am I the doctor? Trust in me." Today my patients ask me, "Okay, doctor, you want me to do silk? Is that even FDA approved?" So the age has changed, the time has changed, and counseling is very, very important, especially when you're doing it to a refractive patient who can live with glasses. It's an elective surgery. What's the aim of counseling? First and foremost, most of our patients who come to us come because they need, it's mainly career-oriented. They need a job, they want to join the army. Those patients are easy to counsel. But the ones who have been living with glasses for a very long time, don't know whether they really want to get rid of it or not, these are the patients whom you need to explain that with getting rid of glasses or doing refractive surgery, your dependency is going to improve. And what I tell my patients is that at this moment, if your glasses were to fall down and break, you would be as blind as a bat. But at the same time, you need to be very, very honest. You need to tell the patient, and the patient will often ask you, "What guarantee do you give me? Or will I get 6x6 vision?" What I tell my patient is that, look, I cannot give you a 100% guarantee. Even if you have a 6x6 vision, there is no guarantee that it will not become less, because at the end of the day, I am not God. And that somehow appeals to the patient. Explaining the procedure is very, very important. Do remember there is a bigger doctor out there, a doctor by the name of Dr. Google, and now we have artificial intelligence to add to it, and so your patient probably knows much more than you do. So explain the thing. Do not treat him as someone, who's dumb or dark in the dark. If you have a model, use it. I use my iPad to show them the procedures. So show them all the procedures, explain all the procedures, tell them why you think silk is better than LASIK. Benefits, of course, there's a high success rate, but I'll be repeating myself, and I cannot repeat this enough. Do not tell a patient that it's going to be 100% successful. Patients will come to you with 6/9 vision and then expect it to be 6/6. You cannot give that. And believe me, there are, with the media, with the social media, you have so many people claiming that they can do that it's really, you're on the back foot while counseling a patient. However, do explain to the patient the freedom that they will have after that they have done the refractive surgery. Benefits, of course, there are some benefits which is there for everyone to understand and see. You have a better lifestyle. Who likes to wear something heavy sitting on the noses? Sports, this is an absolute necessity for sportsmen. Swimmers, they can't swim with their glasses on. Professions, certain professions, and more of these professions now demand for refractive surgery. Very recently, NASA has said that you need to do refractive surgery and get rid of your glasses. The Army, the Navy, the Air Force, railways, they're all asking for it. Risk. You cannot keep stressing on this. Dry eye, yes, it is a side effect. It's not really a risk, but do explain to the patient that you'll be giving them lubricating, so you can deal with the dry eyes. Halos and glares, you need to be very honest about it. All of refractive surgery causes some amount of halo and glare, and if the mesopic pupil is large, then there's every chance of the patient having that. Explain to him and teach him how to deal with this. Infection, very, very rare, but it's not that you cannot have it. You can always have that. Ectasia, again, if you're on the safe side, if you are, like me, a surgeon who likes to play safe, it usually does not happen. Undercorrection, overcorrection, no guarantee against it, so explain to them that there can be enhancement surgery. One thing that you really need to explain is presbyopia. Tell the patient that yes, if you're doing it at a young age, there will come to an age when you will need glasses. This is aging process. I cannot do anything about it. Preoperative instructions, well, you need to tell. you need to tell the patient that you have to get rid of your contact lenses, and it's better that you tell them on the very first day of counseling. Also, post-operative instructions, it's always better to tell them about the eye protection. The activity restriction is something that you really need to stress, because patients want to go to the gym the very next day after doing a LASIK, or they want to go swimming, or they want to train for the army. So you need to tell the patient the very first day that there is going to be a certain amount of time, maybe 15 days, maybe a month, where you will have to restrict your activities. Encourage questions. Please, unlike my father, do not tell the patient that I am the doctor and you are not. You have to answer all the questions. If the patient does not ask you questions, you ask the questions yourself, clarify everything, and take as much, give as much in written as possible. Conclusion, counseling, a good counseling builds up trust, and believe me, it gets rid of all the sleepless nights you have when you land up in a fix after surgery. And as every refractive surgeon will tell you, doing refractive surgery is really an act of bravery, because you're touching an eye that usually has 6x6 vision. So do not, do not bring in a headache after surgery. Take all the headache that you need to take prior to the surgery. Spend time with the patient before the surgery so that you have to spend less time afterwards. Thank you for a patient hearing.
Very nice one. I think you have covered most of the points very well. And counseling is the key of refractive or any premium surgery. If your counseling is good, you are going to be happy afterwards. Doing surgery is one thing, but giving a proper counseling is very, very important. And as you have already said, never overpromise, do underpromise. And I tell most of my patients that this surgery is for reduction of number. I never say it's for removal of glasses. So even if you're writing in your prescription, write advice surgery for reduction of number. Then you are also safe, and you are not over-promising anything. Thank you. Thank you. So we have the next speaker, Dr. Anil Kumar Srivastav, a very leading eye specialist from Gorakhpur. He has a tremendous experience in refractive and cataract surgery. Dr. Anil Srivastav, please.
Thank you, sir. Good morning, everybody. My topic is surface ablation with smart pulse technology. PRK is not new. It was the first FDA-approved laser vision correction procedure before LASIK. Doing PRK since 2002 after mechanical removal of the epithelium. Not happy due to pain and slow recovery. I added smart pulse technology with reluctance in 2017. So there are three things: the PRK, trans-PRK, and trans-PRK with a smart pulse. So I will not discuss about the science or method of doing trans-PRK, but share few personal experiences because I have done all the three. Smart pulse technology came with the promise to reduce residual roughness, better smoothness, and give a whole range of customization. I was not convinced that it can bring significant difference. I thought it is a marketing gimmick. But surprised to see the final outcome of painless post-operative period after SPT or smart pulse technology in surface ablation. Now the pain or discomfort is lesser than 5%, easily managed with oral analgesics in first 12 hours. Vision was nearly 6x6 in immediate and the next day post-op, slight drop from third to fifth day, and satisfactory visual improvement by 7th day. So vision was nearly 6x6 in immediate and next day post-op, slight drop from third to fifth day, and satisfactory visual improvement by 7th day. After 2 weeks, there is no difference in visual outcome between trans-PRK, flap-based surgery, or lenticule-based surgery. So comfortable that I don't call them on next day, but I call them for the BCL removal after 4 to 5 days. I did some change in my practice. I usually remove, initially I used to remove BCL after 7 days. Now I'm removing after 4 days. Initially I was not giving steroid, but I started steroid from the day of surgery. It made a lot of difference. Ketorolac was used for 7 days earlier, but now I used only for 2 days. I thought that any brand of BCL will work equally good, but many times I tried different brands, didn't work as well. All of them came with dirty deposits, sticky debris, and even the epithelial haze was little more than the Johnson & Johnson AQView BCL. Dramatic difference, no financial interest, only to share that there is a difference. In December month, MMC was not easily available. So I thought I used MMC since 2002 in every case, whether it is diopter 1 or less or more. I thought that at least in the lower power, it is not so significant. I did about 50 cases without MMC due to non-availability. Haze clearance took around 2 to 3 weeks, longer than the initial one. And 2 cases are still suffering with the haze. Thanks God that they are not steroid responder and still on the steroid. So MMC is very important, even for the smaller power. So trans-PRK with smart pulse is the 3rd generation. It is not the same what was the trans-PRK. It is not the same what was the PRK. It's good that I have stopped flap making by keratome or femtolaser since the end of 2018. It gives a little higher range of correction without any tension of flap-related complications. Thanks. For any question?
So please.
We take at the end of the session. If you
So next speaker we has with us Dr. Vardhan Kankaria. He is one of the very dynamic young eye surgeon doing a lot of research also in refractive surgery and giving newer ideas. Dr. Vardhan, please.
Okay.
So PRK has come in a new avatar now, advanced surface ablation, and so is ALK in a smile.
Okay, thank you so much, sir, for the kind introduction. And again, from the scientific committee of AIS, I welcome all of you to this midterm conference. Thankful to also the Punjab Ophthalmological Society for all the amazing hospitality. So friends, what I'm going to talk to you about is going to be the smile procedure in more challenging situations. We know that when it comes to refractive surgery today, there is no one procedure which can be called as the best. In fact, there is a role for all procedures. There is a role for smile, there is a role for contoura, advanced surface ablation, phakic IOLs in their own subjective indications. Smile has stood the test of time. We have been using Smile for last more than a decade now. We have done probably more than 10,000 eyes. And this remains as a predominant procedure for me, especially in patients who have mainly spherical refractive errors. But in some patients where we are actually dealing with also high astigmatism, but they are athletes, I would not like to make a flap for them. Actually, if In normal situations, I would prefer a contourer for them compared to smile. But if I don't want to make a flap, such as in athletes, what we do is called as a cyclotorsion compensation by doing a manual mark on the cornea, the way you would do for your toric lenses. Then when you're actually aligning with your alignment reticule on the microscope, you can align your docking apparatus in such a way that these marks, they get aligned, and you can actually have a very compensated very good astigmatic control. And in this patient with -6 diopters of sphere and -3 diopters of astigmatism, we could get absolutely a bang on target, and we have a big series of such patients, and they have done extremely well. Of course, there have been patients where you have other situations when the lenticule gets stuck. Fortunately, we have not had situation when the lenticule was ever torn. But sometimes, or rarely, if you're dealing with low myopia, you may actually land up going to the posterior interface first rather than going to the anterior interface. And in that situation, you have to be careful, and you have to actually go again inside and make sure that you use the fulcrum of your dissecting, let's say the first small apparatus to go under the posterior interface very easily. And if you can do that, then you can actually go and dissect the posterior interface even after the anterior interface, even after you have already done the posterior interface dissection as well. So this actually gets you out of this sticky situation. Can smile be done in patients who have already pre-existing corneal scars? So this was a patient who had presented to us who had a glass injury when he was a child, and you can see it in the center. Also on the ASOCT, he had almost 100 micron clear linear cut on the cornea, which had developed into a scar. And if you look at the profile of the application of femtosecond, you will see that there is a linear area where the femtosecond laser application has not happened. But now the beauty of femtosecond laser is because of the cavitation bubbles, you have a collateral dissipation of those bubbles, and that can actually lead to very good dissection in spite of having such scars. Of course, you should not deal with very intense and very macular grade scar, but such faint scars can be dealt with very easily. As you can see, I'm going in, I'm dissecting the lenticule without any issues at all. And once this dissection is done, I'm going in, I'm removing this lenticule in one piece. And it was a very successful treatment in spite of having a corneal scar. So basically, the presumption that we had that the smile or any femtosecond application cannot be done in scars is actually untrue. You can selectively choose a patient like that. Now, this is a very interesting patient who had been an abuser of contact lenses, and you can see that the peripheral corneal neovascularization was very florid. Of course, you cannot make a flap because actually your flap cut in the periphery will just bleed. So we decided to perform a smile on this patient by reducing the optical zone. As you can see here, the beauty of the femtosecond laser platform is that you can completely customize your incisions, and therefore you can see that incision that I had chosen for this patient was not superior that I traditionally do for all my smile patients, but it was actually temporal. And after doing this temporal incision, we actually took this patient to the Lumira microscope because you cannot perform dissection on Visumax if you are having a temporal incision. And we removed this lenticule in one piece. So this is a small procedure that you can see of the same. So you can see that this is a patient. We have docked the eye. You can see already that the conjunctiva is trying to prolapse because of this peripheral, lot of florid blood vessels and loose conjunctiva, but we are going ahead very well. This is a relatively smaller optical zone of 6 millimeters. Usually I go by 6.5. The incision here is temporal, which is very different. Now I have gone to the Lumira microscope, and I have been sitting on the way I sit for my phaco on the temporal side. You can see a lot of neovascular twigs at 6 o'clock as well as at 12 o'clock in this particular patient. Once this lenticule was basically, the layers were identified, of course, the rest of the dissection was a cakewalk, and we actually could have a fantastic outcome in this patient. This is another very unique patient because this patient had undergone PRK when he was a child in somewhere in Gujarat, and this patient actually had a progressive myopia naturally, and this patient had now a high myopic astigmatism. So this patient came with a amount of corneal thickness which was still possible to go ahead with enhancement with smile. The previous procedure was done almost more than a decade back. I was very, let's say, skeptical of performing smile post-PRK patient because we didn't know how the corneal collagen fibers will behave, because there was also a mild haze that we could see. But this is the application of femtosecond laser in both the eyes, as you can see parallelly. and we could actually have a very, very smooth dissection, in fact, smoother than most of our other patients. In this patient, I had gone for 3 mm incisions of SMILE instead of 2 mm because I had already presumed that maybe because of the previous PRK, maybe we will actually have hindrance in dissection. Fortunately, we didn't have any, and we could actually dissect the lenticule very, very well. So this is the patient that we had done in 2015. So this is almost 10 years ago, and you can see this is the preoperative map, which was post-PRK. This is the first one is 1 month post-op, 2 years post-op, and 4 years post-op tomography. This is the case that we published finally in the IJO, and this is now having a 10-year follow-up, and this is the world's first such case where we have utilized SMILE as an enhancement tool post-PRK. Now this is the last couple of slides and then I will close. So basically this is a very interesting case where we had been referred a patient who was done elsewhere with SMILE. This patient had developed epithelial ingrowth. You can see that there are isolated epithelial cell nest in the center, and now of course because the epithelial ingrowth was in the visual axis, we had to remove it. And the best way to go for, because you can also go through the small incision, but in this case you will probably induce more epithelial cells going in, and this particular patient did not have an epithelial fistula. So what we did was called as a circle software. With circle software we actually converted this cap into a flap, as you can see in this video. The circle software is basically a donut shaped application of the femtosecond laser currently available only and only with the Carl Zeiss VisuMax. As you can see here, I have gone in the same lamella cut. I am going ahead and raising the same lamella cut but the new side cuts, creating a new flap. And you can see I have removed these epithelial cells from both the underlying surface of the flap as well as the overlying surface of the stroma. Using mitomycin C, a bit of absolute alcohol, put the BCL in place. And this patient actually did extremely well. We have published this case in international journal called as the JRS, Journal of Refractive Surgery. This is also the first such case of utilization of circle software in this particular situation. So because of the want of time, I think I'm going to skip the last couple of cases. But yes, definitely SMILE can be performed in spite of having a very, very challenging situations in variety of situations. SMILE currently, definitely as far as the Calyx platform goes, currently is the most mature platform, and we have been extremely happy with the procedures as such. Thank you very much for your kind attention. Thank you. Thanks. Yeah.
Thank you so much, Dr. Kankaria. I think mastering a tricky situation is what make you master. So in refractive surgery, we've got a lot of tricky situations and complication also. We have to think out of box, and that's the way Dr. Kankaria is proved. Yeah. Thank you so much.
Thank you, sir. Thank you so much.
And next speaker, sir.
Dr. Anusha Ajwani, post-LASIK epithelial ingrowth causes, clinical features, prevention, and management.
And Dr. Mahipal, sir, who's you can come here also. Please. Dr. Mahipal is busy in court martial. Dr. Anusha is here? I think she's not here. Yeah. So comparative analysis of visual acuity, dry eyes, scores and contrast sensitivity after silk and SMILE. So silk is getting a popularity nowadays, and we are getting better SMILE also machines. So things are improving a lot. So let us see what is there in the score.
Good morning, everyone. I am Dr. Raghav Malik from Center for Sight. I am speaking on Dr. Mahipal Sir's behalf. I am a consultant to JJSV, and also we do receive research grant for clinical trials. So this is a study which is possibly the first in the world to compare the visual outcomes, dry eye, contrast sensitivity, following SMILE and silk. So we have been VisuMax users for the past decade now, and we also were the first to use the SMILE, the silk platform, that is the ELITA. So we do have a more than a decade experience in SMILE and about half a decade experience in silk. So this is just a comparison of the machines. So if I compare the VisuMax, so these are currently available lenticule platforms. One is of course the VisuMax 500, that is the original Calyx platform. Now we have the VisuMax 800, the Zima, that is the Z8, the ATOS by Schwinn, and the ELITA by Johnson & Johnson. So if I just compare the VisuMax and the ELITA, so what the major difference is, of course, the laser frequency. So we have gone from a 500 kilohertz to a 10 megahertz. So the jump is phenomenal. So of course the laser machine has become very, very fast. Also the energy per pulse has decreased. That is the major factor that is giving the advantage of those very smooth dissections. Then the laser cut time has decreased from 30 seconds to about 16 seconds. And also the patient interface is curved in the Visumax, vis-a-vis that in the Elita it is flat. So a flat interface actually means your cornea is getting flattened after applanation. So the advantage you get is you can do a post-docking centration. That is, the lenticule can be moved around once you have docked. Number one, and also once you have docked, you can do a cyclotron compensation for high cylindrical powers. The machine does not have an inbuilt automatic centration. We do have manual centration that we can mark the 0, 180 and the center of the visual axis, and after docking, the lenticule can be actually just moved around. So the lenticule geometry is also one of the most important factors. The lenticule geometry in a Visumax is a plano-convex. That means one side of the lenticule is plane and the other side is convex. While the lenticule in the Elita or the silk is a biconvex. That means both the surfaces are convex and both the surfaces are refractive. So this is the advantage that you're getting in the Elita. So on the right side you have something which is the Elita, and on the left side you have something like the Visumax. You have smaller bursts of energy that are placed close to each other. So this is what happens when you tear something which has a bigger laser spot size that is separated by bigger distances. So once you tear this sheet of paper, you're going to see that the edges are pretty ragged and it is difficult to actually tear apart. But then if you have something that has very small laser spots that are placed very close to each other, you're going to have something very, very small. So the edge is of course very clean and it is very easy to cut. This is something that translates onto the cornea. That is why you have very smooth lenticule dissections. But on the flip side, when there are so many spots placed close to each other, there is more energy. So more energy is being given on the whole to the cornea. So the collateral damage can be higher. As of now, we don't have the option to separate these spots, that is increase the line and spot spacing, but soon we should be. So the study design and objective, it was a prospective comparative interventional study where 100 eyes, 50 eyes undergoing silk and 50 eyes undergoing smile were examined at 6 months. The parameters that were examined were UCVA, BCVA, dry eye and the contrast sensitivity. The energy same in the respective laser machine for all cases, that is for all cases we did not change the energy. The Visumax has 26 nanojoules with spot separation 4 and line separation of 2 microns, and the Elita was 32 nanojoules with less than 1 micron of spot separation. As of now we can't change spot separation, but soon we will be. Single surgeon, same surgical technique. So these are just the preoperative parameters for both the silk and the smile group. So looking at the visual outcomes, 96% of silk eyes achieved 20/20 or better versus 94%. So I'm talking about 20/20 or better. So when we had started our silk journey, our energies were somewhere around the 70. Now we have come to 30. So that decrease in the energy is what is giving us those clean visual outcomes and the early visual recoveries. So the plus minus 0.5 predictability was 95% in silk and 93% in smile. So that was comparable. There was no statistical difference. So now this is the main slide. So I'm going to flip between two slides fast. So this is the silk and this is smile. So if you see, the main difference that you are seeing is in the red columns. So the red column means 20/20 on day 1. So if you compare, so this is again silk and smile. So what's happening is that 75% of the eyes actually got 20/20 or better day 1 in the silk, and 50% got 20/20 or better. So of course they were all better than 6/9, of course, that is the least expected. But 20/20 or better, we got in 75% eyes of silk vis-a-vis 50. But of course at 1 month all patients were 20/20 or better, so there is no comparison between silk and smile that way. So there was faster, earlier visual recovery in the silk once we decreased the energy. Refractive stability between 1 and 3 months and 3 and 6 months was same in smile and silk. And the mean change, or the MRSC, in the silk was 0.03 and in the smile was 0.01. So this was comparable. So the change in Snellen lines, that is 45 and 46 eyes had no change, and 45 and 45 eyes gained 1 line at the end of 3 months, and there was a gain of 2 lines or more in the silk group at 3 months and 9 in the smile group. So the surgeon score for dissection, this is where the silk actually scored better because of the small spot sizes. It was easy to remove. So 90% actually said that no, that is grade 0 dissection was required. And now coming on to the difference again, like I said, was in the spot sizes. Now the complications, there were higher complications in silk. Why? Number one, because it's a harder dog. So we had more subconjunctival hemorrhages, that is in the silk group. Now coming on to the incorrect plane entered, so all eyes we entered the correct plane, so the advantage of the biconvex lenticule lies here. So if you see the edge is biconvex, so going into the upper and lower plane is much easier. So there was none of the cases where we actually entered the wrong plane. Dry eye parameters, they were comparable both in the smile and the silk, there was no statistical difference. Then contrast sensitivity, smile actually lagged, silk was leading. Why? This is one of the earlier cases of the Elita. If you see, just under the microscope, the cornea or the surgical surface of the Elita is much cleaner compared to the smile. This is under just a regular microscope, but again there was no statistical difference in the contrast sensitivity. So to conclude, both smile and silk are adequate for lenticular extraction at 6 months. 95% of the silk and 90% of smile eyes were within plus minus 0.5. Visual recovery was faster with silk. Incidence of non-visual side effects was higher in the silk eyes. Silk felt slightly better in terms of dry eye, but it was statistically insignificant. Limitation was we require a larger study. Surgeons may have a bias and need contralateral study, that is one eye smile and one eye silk, to actually get a better answer. Thank you so much.
So Dr. Raghav, you compared it with Visumax 500.
Yes, sir, with the 500, yes, of
course. But Visumax 800 is, how do you compare with this?
So we don't have it, so I cannot do a direct head-to-head trial.
I think once you are comparing the advanced machines, you should take both the advanced
Yes,
ones.
of course, that definitely will be a better trial, sir. But
Smile was the first, I think Visumax was the first machine, then the better machines came.
Yes.
Visumax 800 is also good.
Yes.
I think Elita is also good. So
of course,
the comparison can't be done with the older version.
Like I said, so all machines at now are giving you 6x6 at 3 months. There is no comparison that way.
Dr. Kankaria, you're comparing Visumax 500 or 800. You can.
Contractual study.
Yes.
Which requires some ethical approval. Also time. Stability. Yes, stability. Silk has gone through some troubleshoots in the beginning. Now it has come to some good stability. So definitely we are in exciting era that a lot of KLX platforms are fighting with it. Yes. Thank you, sir.
So the competition makes the things better, I think.
Thank you, sir.
Thank you, Dr. Raghav.
Thank you, sir.
The next, please, sir.
Yeah, please. Now we invite Dr. Sarabjit Rajan, ophthalmologist from Punjab, wonderful surgeon. He will be sharing his experiences with silk lenticule extraction.
So, good morning everyone. So, I am here to share my experience with the silk laser surgery. Dr. Raghav has covered most of the theoretical part, so I will not go to that part. So we have started our silk in 2025 in the second month of this year. So my experience, introduction, what this system is. As Dr. Raghav has already told, I will not cover the theoretical part. It's a low energy treatment as compared to the other system. This is the just 40 to 90 nanojoule per pulse, and spot size is very small, 1 micron meter, ultra short pulse duration, and ultra fast pulse frequency. So these are the differences with the other system. Though the main system is the Y-convex lenticule, which the Dr. Raghav has already told in the last presentation. So this is our OT, and we are doing this is the vacuum ring placement and docking. Lenticule and side incision formation by Elita femtose second laser, and gentle incision opening, and first anterior plane dissection. So this is the surgery that we are doing in our OT. So the main feature, this is the video of that, the cyclotorsion. So after flat implantation, we can do the post-docking centration. Like in this slide, you can see that we can, after applanation, we can adjust the parameter. We can adjust the margins with the margins that we have marked with the blue dye. So this is the main feature of this system, that's post-docking centration enable better visual outcome by minimizing higher order aberrations. So this how this machine works. So this the silk is going on. Okay. So lenticule and side incision formation. This is the system that provides the. Although I don't have any financial interest, Alita system provides laser with low energy and small spot size, leaving no pulse separation, which lead to continuous tissue resection with minimal residual tissue breakages, and therefore less lenticle manipulation for tissue and ease of lenticle removal by surgeon, leading to less keratocyte activation and reduced immune response, resulting in a fast recovery. So this is how we remove this is the dissection. The meniscus sign is very important. First we go into the anterior plane, then into the posterior plane. This is the meniscus sign. This is very important to differentiate between the anterior and the posterior plane of the lenticule. So the biconvex shaped lenticule, the importance of this is the less collagen fiber, it expected to cut the less collagen fibers in the peripheral cornea by cutting deeper into the stroma, thereby producing less opaque bubble layer and better preserving corneal biomechanical strength, and minimal disruption of the peripheral collagen network in the anterior stroma, constituting approximately 60% of the total corneal tensile strength. So this is we are dissecting the posterior part of the cornea, sorry, lenticule. Energy optimization is very important. Like in the initial cases, we have the tough dissection, but in the last few cases, the dissection is so smooth and it take only, I think, few seconds to remove the lenticule starting from the start of the procedure. So this is the importance of the biconvex design, that edges of the lenticule are more posterior in the cornea compared to the planoconvex, and this area has low density collagen fiber and corneal nerve, which supports faster nerve regeneration and healing. So this is more theoretical. You can see why it is more good. So there are the few complications that the complications arises when startledly we have a patient come with a number of minus 1.75. I asked him to go for the LASIK, but he said no, he will go for silk only. So we did silk, and this is the silk OD treatment summary. These are the post-operative pictures. Everything seems to be good, but when we started, because in the thin lenticule, the wrong plane dissection is the most common complication that happens. So first we have to dissect the anterior plane, but I was thinking that I am in the anterior plane, but unfortunately I was in the posterior plane. So when I have got this, that the anterior part plane is still there, so I tried to get into the anterior plane, but which become difficult. So I'm not getting that how to enter, and so many attempts just to find out where is my opening of the anterior plane. So always this is the thing that, so I tried to hold the anterior lip with the forceps and tried again, but so this is very important. The entry into the anterior plane first is very important. It is mostly happen in the thin lenticule when you are doing with the surgery of a very small number. So this is how I entered the anterior plane, and rest is everything fine. When you get the plane, then everything is good. So this is how we remove the lenticule. Only few This is the another complication, suction loss, although we have not any suction loss so far. So there are the little complications, two more complications. I will take only few seconds more. So this is the folding of the lenticule. This always happens when you deal with the thin lenticule, or you don't have the fulcrum you didn't left from the one side, and the overconfidence is the second reason. When you say that it is just a 10 seconds game, so when you start in hurry and but something, this folding happens, but can easily be taken out, these folding. So last complication, so you can see that I have insected from the posterior plane and then remove the lenticule. So this is the lenticule tear, another complication. So this happens with the inadequate ablations and with the OBL. So you can see the part of the lenticule is inside the pocket, and the tear is also there. I tried to remove it, but the little force. Then on the second day, I have inspected the lenticule, that there is a retained lenticule, but everything was good. And on the second day OCT, we didn't found any retained lenticule into the pocket. So you can see that everything is fine. So complications, so these are for the beginners, the complications are more likely to rise during the initial learning phase, with the majority attributed to lenticular dissection and extraction challenges. More technically challenging, like the new surgeons, low myopia, complicated orbital anatomy, high astigmatism, these are the patients to be avoided. So in my experience, Silk is highly successful, consistent, safe and effective treatment of myopic refractive error with or without astigmatism, and easy lenticular removal and fast visual recovery were demonstrated, with no serious adverse events, although mild corneal edema, peripheral corneal scarring, hemorrhage were noticed in few cases, which subsides at the end of the first post-operative week. We did, in last few months, we did 206 eyes, 206 eyes. With Silk, and complications are more likely to arise during initial learning phase, and results are excellent and after proper energy optimization and surgical skills. Thank you so much.
Thank you so much. I think the technology keeps on improving. While the LASIK has matured a lot, but smile technology is always progressing now and improving a lot. And still we require customization treatment, hyotropic treatment. That may be in the pipeline. I think that will come in the future. Thank you so much. So moving from refractive surgery, we are going to lenses beyond monofocal optics, the IOL choice. Dr. Charan Kamal. So cataract is the most popular refractive surgery, by the way. So everybody who's doing cataract surgery is a refractive surgeon. Dr. Sonu Goyal is here.
Thank you, sir. Good afternoon, everybody. First of all, I welcome you all to Amritsar, the city of Golden Temple. Shifting from LASIK, we are going to cataract. I'll be discussing about Vivinix Impress, and I assume most of the eye surgeons in this hall have already had an experience of implanting Vivinix Impress lens by Hoya. Vivinix Impress is an EDOF lens manufactured by Hoya company. It is aspheric spherical aberration correction lens tolerant to coma. Aspheric design is tailored for improved intermediate vision, testing visual outcomes that are more tolerant to residual refractive error than a standard monofocal IOL. The metal is hydrophobic acrylic, glistening free, no calcification, C-loop 13 mm diameter, full 6 mm optic, very low PCO rates, and outstanding rotational stability. The preloaded injector system of Hoya, as usually, is outstandingly smooth and controlled delivery consistency, push or screw insert shield for insertion depth management. The extended depth of focus provided by an enhanced monofocal IOL provides the following benefits compared to the standard monofocal IOL. It gives a wider range of focus for intermediate vision performance and improved outcomes in the presence of residual refractive error. Distant visual acuity must be clinically equivalent to a standard monofocal IOL, and the incidence and intensity of photopic phenomena must be similar to that seen amongst patients groups implanted with standard monofocal IOL. This is a range of vision in case of Vivinex Impress IOL. The standard monofocal IOL gives far vision, and the Vivinex gives the intermediate vision. Vivinex Impress is a novel aspheric design tailored for improved intermediate vision, designed to provide a wider range of focus for intermediate vision without compromising the distant vision, which remains comparable to a standard monofocal IOL. Enhanced monofocality should also mitigate the impact of residual refractive error. Optical design should ensure a stable quality of vision and decrease sensitivity to the impact of decentration or tilt. Its central part 2 mm has a smooth combination of an even order and standard aspheric surface. Peripheral part has a standard aspheric surface. In the peripheral region, the profile converges to that of a standard aspheric IOL to provide a good distant vision. The transitions between the region are smooth, and the surface looks like that of a standard monofocal IOL. Vivinex Impress is insensitive to decentration. In case of 0.4 mm decentration, the reduction in contrast is lower as compared to a standard negative aspheric monofocal IOL. This is a small video. Excuse me. Excuse me. फॉरवर्ड कैसे करना है? हाँ, फॉरवर्ड कैसे करना है? हाँ,
कीनोट है ना आपका, ये कीनोट में फॉरवर्ड नहीं होगा सर?
नहीं होगा?
नहीं, इसमें नहीं होगा.
You can continue next one. You can make it forward for surgery.
He can forward the thing. That's what I was asking.
Lens particle to show.
I just wanted to show the portion of lens being implanted, but he cannot forward it. हो गया, अभी तो हो गया बस नहीं, अभी नहीं, मत करो, फिर से हो जाएगा शुरू. The implantation part will come now. The injector system of Vivinex has got a insert shield, and it can be pushed. At the same time, we can move it with a screw. It depends on the preference of the surgeon, which one he likes to use. I'll show you the injector system now. This is the injector system of the Vivinex. There was a small aperture to put the methyl, and there's a lock system. We can gently push the IOL up to the tip. The tip is 1.7 mm, which can easily go through 2.2 mm incision. I think we are short of time because the video couldn't be edited. This is the range of focus, and these are the physics of the IOL. The unique feature of multi-set is single-handed push or 200 screw injection, which I've already explained. And the unique design adjustable insert shield provides additional assurance. Modulate the insertion depth according to the preference by inserting the injector tip either directly into the capsular bag or through the incision wound tunnel. This is a data sheet of the Vivinex IOL. Thanks for patient hearing and viewing. Thank you.
Very much. I think Hoya has got one of the best injector system also.
Definitely.
Yeah. Thank you.
Now we invite Dr. Gaurav Gupta. Phakic IOLs made easy, please.
I think the next speaker should be ready with the presentation if they have to do this one. Dr. Sonu Goyal is there? Dr. Gaurav Mishra, you loaded? You? Okay. Take your time to set up like your own laptop.
A very good morning to all. At the outset, I would like to thank AIOC to give the opportunity to speak in front of you all. I'll be speaking today on phakic IOLs made easy. The slide is not come on. Yeah. So the aim of today's presentations is so that everyone who is not doing phakic IOLs today and is a cataract surgeon or a good phacosurgeon can start doing phakic IOLs. What we call is an ideal refractive procedure is which is something which is easier to do, safe, effective, reversible, repeatable, free of complication, cost effective, and does not require big machines. So phakic IOLs are a very promising thing. Phakic IOL is something which is implanted inside IOL in presence of a natural crystalline lens to correct the refractive errors. Since ages, we have posterior chamber angle fixated or iris fixated phakic IOLs. For the present, today's talk will stick to posterior chamber phakic IOLs, in which an implant is placed behind the iris and in front of the lens, that is in sulcus space, which is a potential space. So what are the advantages of placing it behind the iris? It is far from endothelium. It has excellent cosmesis. It is close to nodal point, gain in retinal size, and greater effective optical zone. And as it is sulcus located, it has stable location, easily removable or exchangeable, do not alter or remove tissue, and it is a completely reversible procedure. So phakic IOLs are presently coming with by Star Surgical ICL or IPCL by Care Group or Biotech phakic IOLs. So previously they have been coming since long, but in the old design there was no central hole, due to which there was chances of IOP rise, but in the latest design they have a central hole, which decreases the chances of IOP rise.
Chamber phakic?
So here I'll be demonstrating a video.
Posterior chamber phakic lens is implanted behind in previous version of
So here we can see the aqueous could not come up, due to which there was chances of IOP rise and due to angle closure. But in the latest design, as there is a central hole, the aqueous can easily come out, and it also helps in easy removal of viscoelastic, which could have been left behind the phakic IOLs. So traditionally the indication of phakic IOL have been in the high refractive error or the patient which is not fit for the procedures, but nowadays the era is changing. There are a lot of people who are doing phakic IOLs, and in present scenario anyone age more than 21 having stable refraction. since 1 year and wants to get rid of glasses, we can directly go ahead with phakic IOLs. So, but still, there are a lot of contraindications, like if there is progressive refractive error, any corneal dystrophy, endothelial cell count less, any history of uveitis, posterior cyanic, any angle pathology, or pre-existing cataract, or any family history of retinal detachment, then still there is no, also history of diabetes mellitus. There are a lot of advantages of phakic IOL over LASIK that it do not have chances of dry eyes, as we are not cutting any corneal nerves in these cases. And correction can be done up to any number. It is reversible, less chance of regression, as we are not touching the cornea, so chance of regressions are very low. And the quality of vision is very good in these cases. It has excellent safety and can be done in thin corneas as well. So there are a lot of data over it in which they have shown that in LASIK there has been reported regression in longer duration, that is 0.11 diopter increase happen every year. And visual performance of phakic IOL has been compared in low to moderate and as well as in high myopia, and it has been shown to have a better quality of vision in cases of phakic IOLs. But still there are few disadvantages. The main is the cost, and also in toric phakic IOLs there are chances of rotation also, and it requires a lot of experience. So workup is the key. Refraction is of fair amount of importance in all refractive procedures. Topography is very important in pachymetry, internal ACD, wide-to-wide, and dilated fundus examination. ACD can be easily measured with any optical instrument, maybe AIOCMTC4. The point here is to highlight that internal ACD is required, that is from the posterior surface of cornea to the anterior surface of lens. Some optical biometers gives the external ACD, so we have to decrease minus the CCT in that. Another thing is wide-to-wide measurement. I think this is the most important thing for planning of phakic IOLs. The horizontal wide-to-wide measurement has to be very accurate. So gold standard is digital caliper, but a lot of machines are like Pentacam, your biometers give, which is not very much accurate. So we can measure the wide-to-wide in OR or in slit lamp. So I'll just skip this thing and show the main part. So wide-to-wide measurement, we have to take the central wide. The limbus is very wide, not the external, not the internal, the mid-limbal area. Like this is the external, this is the mid-limbal. So the mid-limbal part has to be measured, because if we will not measure it properly, the sizing is a big challenge. So tips and planning is good refraction, accurate ACD, and wide-to-wide, and when in doubt in borderline cases, go for a higher lens. So now I'll be demonstrating the procedure in very short. So the standard main port and side ports are made like a routine phacoemulsification we do. And then AC is inflated with the help of viscoelastic. Here the care should be taken. Always use dispersive viscoelastic. Do not use sodium hyaluronate or a cohesive viscoelastic, because that increases the chance of cataract. Then the phakic IOL is loaded. Loading is different in all by different companies. This is the Biotech phakic IOL which I'm demonstrating. I think this has the easiest loading thing, like routine IOL. Here the tip is never do wound assisted implantation. Always insert the nozzle inside and then do not inject it like an IOL. Go very slow and let it open, and look for the hole if it is in the right orientation, because many times it flips. And once it is inside, then we just need to tuck in with the help of a tucker underneath the iris. Like in IOL, we go straight down. In this, we have to keep it in the horizontal plane. And once it is implanted, it is already centered. We just need to take the viscoelastic out. Viscoelastic removal has to be complete. Otherwise, there are chances of IOP rise in the immediate post-operative period. But otherwise, it is very much fine, and the surgery is done in a nicer way. So in the post-operative management, just check for IOP and standard steroid antibiotic and look for vault. So vault is the most important thing in the post-operative period we need to look for. So vault is the space between the posterior part of the phakic IOL and the anterior surface of the lens. It has to be measured. We can measure it clinically or on anterior segment OCT. It has to be 200 to 700 micron. If it is lower, it will increase the chance of cataract. If it is higher, then it will increase the chance of angle closure or raised IOP. Otherwise, it is fine. So complication may be high or low vault, rotation of toric phakic, cataract, raised IOP, pigment dispersion, inflammation, infection, but they are very less commonly seen. So I'm showing few results of biotic phakic IOLs. I personally feel it has a very simple loading, and it goes with 2.8 mm incision, whereas STAR required 3.2 mm incision, and no special instrument or there's no special forceps or anything is required. The simple injector of IOL is effective, and it is also cost effective. And long-term results have a lot of data, and multiple publications has been published that it is safe and effective in a lot of cases. So take home for today is no single procedure is best for all cases, but refractive procedures are to be tailor-made as per patient need. And still, phakic IOL is safe and effective for refractive surgery, and definitely it's not the last resort. I personally feel it is the first resort. And phakic IOLs have less chance of regression and dry, so that is a point to be considered. Thank you all.
Thank you very much for this illustrative view. And why not you use the sodium hyaluronate?
I said we should not use sodium hyaluronate.
Reason?
Sir, because sodium hyaluronate has been reported, when it comes with the contact of natural lens, it increases the chance of cataract. There are a lot of data on that.
But with the ICL, we are regularly using it.
Maybe,
I found it to be very, very good.
Maybe, sir, we are removing it completely, so that is the thing.
Okay, thank you very much. We have short of time. And our the last but not the least, probably we have the best for the last. Dr. Gaurav Mishra from Meerut is a very dynamic surgeon. Dr. Gaurav, please.
Thank you, sir. Probably I am the last batsman here today. So I'll not take much time because most of the people are sleeping. I'll just be fast in my presentation. So this is a sponsored talk by Elcon. So this is the Elcon digital innovations that is enabling you to seamlessly power your practice to deliver outstanding patient outcomes now and in the future. Because cataract surgery is the bread and butter of everyone. Everybody is talking about lenticules and bladeless surgeries, but cataract still remains the bread and butter. So seamlessly power cataract surgery with full integration, precise and predictable. And the biometers that are coming today are the best ones. They are the digital microscopes, the Luxor, the Centurion machines, and the vision systems. The Luxor Revelia, which I have, I think it is one of the best microscopes. It has a super visualization, larger depth of field, 6x larger and more stable red reflex, and it integrates with the Argus and DMM and Centurion vision system, which is the most important thing. That is why sorry.
So it can be used with a particular microscope or any microscope?
Sir, any microscope you use, but you have to have a Argus with the Varion so that it can be integrated. Plus, once you have the microscope, you have a free overlay with it. So that is the advantage of that. So the integration of the system is very good. And all these things, even when you are doing a grade 1 or grade 2 plus cataract, it seems like a no cataract surgery, like a Californian cataract. So this is the main thing, the Argus, which has a digital marking system. There is a control and evaluate measurement quality in real time. The only biometer with vision planner with expected outcomes in real time. The SIA and A constant can be optimized for further precision. The ARC integration nomograms are there, and the best acquisition rates in hard grade cataracts. And believe me, I am not telling you false. Even in grade 4 cataracts, we can have the biometry done in Argus. And we have a pre-op, intra-op, and post-op results. And this is what the ERV mode stands. There is a higher acquisition rates in grade 4 cataracts compared to the IL Master 700. Probably Dr. Anil would not agree with me, but I have my own results here. And you can see in the OCT, without ERV mode and with ERV mode, you can have the idea of the retina also. This is the normal and this is the ERV mode. And plus, you have a segmented axial length calculation. That is, with this, the swept source laser detects the reflections at each interface in the eye and uses this detailed refraction information along with the refractive index for each segment to calculate the total axial length. Here you can see very well. And the enhanced keratometry with the swept source. So this is exploring step by step. You can keep your data, you can enter into the OT, and here you can surgically orient this. Then you register it, verify the registration result. Registration is done. Incision is given, the Mendes ring is there. Your incision size are already marked. You have the rexus, which is I keep at 5.5 or 5.6. You have the area where you have to place your lens. And here is the finalization. So this is the compact planner. It has a pre-operative measurements we can do. The planning required, whichever formulas you want to use, you want to have a target, you want to have phakic cataract removal, you want to do it in a phakic mode or a cataract mode or an aphakic mode. You can have a spherical correction planner, then the astigmatic correction planner, and you can expect the outcomes. And with other thing, one more thing is that you can move your incisions. In this you can see you can move your incisions anywhere and you can calculate the residual power that you will be getting. So this is one advantage. The next is the planning for the outcome. ARC nomograms are there where you can give a paired incision or a single incision and you can get the outcomes for the temporary purpose, because these arc incisions are not very long lasting and you may land up into your previous. But some people who are not going in for toric IOLs, I think this is one of the best things that you can do on table to at least give some good results. And here is a simple short film showing the marking and the placement of the IOL. This is just 10-second. And here you have placed at 10 degrees and you are absolutely on dot. So you can outcome optimization in post-operative cases. You can see and analyze your data and get your presentations done. And these are the image-guided precision powered by Elcon. And thank you so much for your patient hearing. Thank you so much.
Thank you so much. I think the technology is improving and we are getting better and better machines. Thank you, Dr. Gaurav, for this.
Had a wonderful session on cataract and refractive surgery, where we could have talks on counseling the patient for refractive surgery, smart pulse technology, challenging cases in smile, silk vis-a-vis smile, complications and problems of lenticular extraction, phakic IOLs, image guidance, enhanced monofocals. Any questions, please? Though we are running short of time, but any questions, please?
I'll request the speakers to come here for a group photograph, please. Sir.